pituitary gland to produce large amounts of another hormone, which is called LH, luteinizing hormone. That's this, that's the line right over here, the top line, which you can see goes all the way up, very high up, right around the time of ovulation. What LH does, what luteinizing hormone does, is it gets the follicle and the egg ready for ovulation. The LH increase is called the LH surge, and this actually causes the follicle to burst, and the egg inside comes flying out, and that's what ovulation is. Now the follicle is like a balloon which has deflated, and the deflated balloon produces a new hormone, which is called progesterone, and you can see progesterone levels on here, also the green, which goes up mostly after ovulation, because after ovulation is when the body makes progesterone. And what progesterone does is it gets the inside lining of the uterus, which has gotten thicker with the estrogen, now it gets the lining ready to accept a potential pregnancy, to accept a possible early pregnancy. The egg is then hopefully picked up by the fimbria, these finger-like ends of the fallopian tubes, and the egg is swept inside of the tube right here where it waits for fertilization by the sperm, as we saw before. And once the egg is fertilized, now the early embryo is moved down the fallopian tube. The fallopian tube kind of pushes it down towards the uterus, and it falls into the cavity of the uterus, and that's where it implants, attaches into the lining of the uterus, through which it will receive all of its oxygen and nutrients and everything that it needs to develop over the next 9 months. If any part of this incredibly complicated process does not function correctly, then the couple, the husband and the wife, might suffer from infertility, or I prefer to call it actually subfertility, from a little bit of a lower chance every month of becoming pregnant than they would normally have. And unfortunately, this actually occurs much more frequently. This happens to many more couples than many people even think. Infertility or subfertility actually affects about 10 to 15% of couples in the general population in the United States, which again is much more than most people realize. Baruch Hashem, nowadays, most of these couples that have some problems can be helped medically, and many couples, or at least some of these couples, need assistance from some of the higher levels of treatment that we can provide, from the higher levels of assisted reproduction, such as IVF. And so now let's talk about what are some of the medical reasons that a couple might need IVF. So IVF is indicated for some diagnoses as a main treatment, a primary treatment, while for other diagnoses, for other conditions, as a more advanced treatment only if less aggressive treatments, if milder treatments don't succeed. In general, infertility or subfertility most commonly results from either a tubal factor, either a problem with the fallopian tube, that's this box right over here, in about 22% of couples who have fertility problems. Again, in the general United States population, within the frum community, this number is actually significantly lower. Obstruction of the blockage of the fallopian tubes is much less common among the frum community, but still happens for various reasons. It happens, fertility issues can happen because of an ovulation problem, an ovulatory dysfunction, that's this red box over here, in about 27% of couples. A male factor, an issue with the husband, in about 25%, roughly. Endometriosis, something you may have heard of, in about another 5% of couples, and in about 17% of couples who are having some difficulty becoming pregnant, the reason for the fertility issue is unknown. We just don't know what it is, despite all the testing that's done for it. Historically, IVF was specifically developed in order to address a problem with a tubal blockage, with a blockage of the fallopian tubes. Al Pisfara, that made sense. The thinking was that if everything is fine with the eggs and if everything is fine with the sperm, and the only problem is that they don't have a way to meet because the fallopian tubes are blocked, so that's where people started to think, let's try to do this outside of the body so that we don't need the fallopian tubes to be working at all. And in fact, Louise Brown's mother, that first IVF baby in the world, her mother suffered from a bilateral tubal obstruction, from blockage on both sides of both of her fallopian tubes. If the woman's fallopian tubes are blocked, then the sperm will not be able to meet the egg. And even if by some chance the sperm were able to meet the egg and fertilization were to happen, the early embryo would not be able to make its way down past the blockage into the uterus. And so fertility problems for the couple will result from this. And now the technique of artificial insemination, which is the topic for a different discussion, will not get around this particular problem. It's not going to help this, because in an insemination, the zera still have to swim all the way up through the fallopian tubes, and the embryo still has to travel down the fallopian tubes to make it into the uterus. So this will not help a blockage of the tubes. Now, for an ovulation issue, first-line treatment for fertility that results from an ovulation issue, from a person who does not ovulate, or from an irregular or a weak ovulation, is inducing, bringing about, or strengthening ovulation, usually using different types of medications, which can be useful for that, with a correction of any underlying hormonal condition which could be responsible for the problem with ovulation. IVF for this becomes an appropriate treatment for an ovulation problem when multiple attempts, when we try many times to induce or strengthen ovulation, to use these types of medications, but that does not result in pregnancy. If you've tried and tried and tried, you've done all the hishtadlus you could possibly think of, and it just doesn't work, then IVF becomes useful. IVF, by the way, in this situation is also useful for a couple where the wife's ovaries are extremely sensitive to these types of medications, especially injectable medications. And if that's the case, then the risks of ovarian hyperstimulation syndrome, which we'll talk a little bit more later, and the risks of high-order multiple pregnancy, like triplets or quadruplets or anything more, might be dangerously high, because IVF makes it much more safe from those points of view also. So IVF can be useful in those situations as well. If the husband's sperm count is very low, or if the sperm motility is very poor, if there are just too few sperm cells, or they're just not able to be good swimmers in order to be able to survive that long journey to meet the egg, then again, infertility or subfertility for the couple can result from that. And if the problem is extreme enough, then artificial insemination, in which the sperm still have to swim at least part of the way to the eggs, might not always be enough to be able to help. It might be enough to help. All you need is literally just one zera to be able to make its way up to the egg. And every day, kol yom, I see situations where we think the chances of a pregnancy are less than 1%, and it happens, and we get a positive pregnancy test. So artificial insemination can help in these situations also, but if it doesn't help, then IVF becomes very useful. And in fact, IVF has actually revolutionized the treatment of male-based fertility of a problem with a husband. The introduction of something we'll talk a little bit more about called ICSI, intracytoplasmic sperm injection, in which a single sperm cell is injected directly into each egg, has helped couples with even the most severe forms of male fertility problems to get to the point of a pregnancy where in the past there were really very few medical options to help with. Even in cases, just a little bit more about the male issue, even in cases of what's called complete azospermia, where there are literally no sperm at all, there's a complete absence of any sperm at all. Liquid comes out, but there are no sperm inside of the liquid. Sperm can be retrieved with a needle, either from the epididymis, that's an epididymal aspiration. The epididymis is the tubes where the zera mature after they're produced, or they can be removed directly from the testis itself. And IVF with ICSI can be used in order to help with a pregnancy. In cases where viable sperm can be gotten, either being produced by the husband or by putting a needle inside of the husband, even just 1, 2, 5, 10 sperm can be gotten, then a pregnancy can be possible with IVF with ICSI. That's very, very doable now. This we briefly touched on. Endometriosis is a disease that can cause both pain and infertility, and this is again the subject of a whole different discussion, a whole different talk. And women who are suffering from the particularly severe form of this disease can often benefit from IVF in being able to help them achieve a pregnancy. And as we saw, about 17% of couples who have fertility problems have no good explanation for the problem, even though we've done all kinds of testing and the testing has all come out negative. These couples can often be treated successfully with ovarian stimulation together with artificial insemination, but if that kind of treatment fails, then they can also achieve very good success with the more advanced assisted reproductive treatments like IVF. And we think the likelihood is that many of these couples, unexplained doesn't mean there's no reason for it. It just means that we don't know how to put our fingers on the reason for it. And we think that a good percentage of these couples who have so-called unexplained fertility problems might actually have some sort of abnormality that we can't see or we can't diagnose, like a problem that prevents the sperm and the egg from attaching to each other, or the sperm from drilling its way inside of the egg. Maybe the eggs have a particularly thick shell or something like that. And maybe this explains why unexplained fertility problems can often be overcome by doing IVF. But we do know that it's useful for couples in those situations. And then finally, nowadays, we're actually doing more and more IVF for couples who do not actually have any fertility problems, but who need genetic testing of their embryos before a pregnancy. For example, if a husband and a wife are both carriers of a genetic disease, such as Tay-Sachs disease, which you've all heard of, and if it was not picked up by any kind of testing prior to the marriage, such as what the Dar Yesharim has taken great strides to try to prevent these kind of shidduchim from happening where this becomes a real issue. But if a couple has not had testing by Dar Yesharim, or for whatever reason it wasn't picked up before the chasana, then this couple will chas v'shalom run the risk of having a child who has something like Down syndrome, which could potentially be a fatal disease, which is terrible. So in order to prevent such a thing from happening, even if the couple does not have any difficulty becoming pregnant, has no fertility problems at all, we can take them through IVF, make embryos, test each embryo to see whether each embryo has Tay-Sachs disease, just to stay with that example, and only place unaffected embryos, only place normal embryos inside of the woman's uterus. And this is called pre-implantation genetic diagnosis, or PGD, we call it. We'll refer to that more later. PGD also can be sometimes used to decrease the risk of pregnancy loss, of miscarriage, in women who have gone through several pregnancy losses. But that's a little more controversial at this point. There have been many significant advances in this area, in the area of PGD, since the first PGD birth in 1990. In 1992, the first successful diagnosis and delivery of a baby free of a single gene disorder was reported. The first was actually from cystic fibrosis. The second was from Tay-Sachs disease. To date, researchers, investigators throughout the world have reported several hundred births from PGD using various different kinds of laboratories. The benefits of PGD include eliminating the clinical risks associated with testing during pregnancy, such as something called CVS, chorionic villus sampling, or amniocentesis, as well as, particularly for the frum community, avoiding the serious halachic and emotional issues that surround a fetus or a baby who, chas v'shalom, can be affected with a terrible disease. From a medical, scientific point of view, let's talk about what an IVF cycle consists of. First, before starting IVF, several things have to be done. A medical history and physical examination have to be performed of particularly the woman. Screening for infections is always done, and this usually includes blood testing for things like HIV and hepatitis B and hepatitis C, things like that. The wife is always checked, and usually checked for immunity to infections that are potentially dangerous if she gets them in pregnancy, such as German measles or chickenpox or other such infections. And if she's not immune to these diseases, then we usually recommend vaccinations, getting vaccinated to these diseases before starting the IVF cycle to become hopefully pregnant. We usually offer targeted genetic screening to couples who are getting ready for IVF, and this is based usually on the couple's race and ethnicity and what type of genetic diseases they might be at risk for. Specifically for Ashkenazim, there's a full panel of appropriate genetic tests that should be done, or if they were done by Dar Yesharim before the chasana, that's fine also. But they should be done to make sure that the husband and the wife are not both carriers for any of the known genetic diseases that are more common, as we know, among Ashkenazim. And by the way, everybody probably realizes this, but just to emphasize, these diseases typically that are common, less uncommon, I shouldn't say common, Baruch Hashem, less uncommon among Ashkenazim, tend to be what are called recessive diseases, which means that a person can only develop that, a baby can only develop that disease if both the mother and the father are carriers for that disease. If only the mother is a carrier or only the father is a carrier and not the other one, then there's no risk, there's no issue at all, and that does not need to be worried about. We need to look at, before starting an IVF cycle, we need to look at what's called assessing ovarian reserve. Ovarian reserve means how well the ovaries are functioning. And this is of critical importance in deciding both on the appropriateness altogether of doing IVF on this couple, as well as deciding on the types of medications and the stimulation protocol which will be used during the IVF cycle. Evaluating ovarian reserve involves taking into account various factors, including the age of the wife, the antral follicle count, which is something which means the number of small follicles that you can see, the number of small little eggs inside of follicles that you can see in a person's ovaries on ultrasound. It includes looking at levels of various hormones such as estrogen and FSH, and sometimes another hormone called inhibin. It involves hormonal testing, dynamic hormonal testing, such as something called the clomiphene challenge test. And it involves looking at a person's ovaries' previous response to injectable medications. If this couple has been treated previously with medications, you want to know how many eggs did the person produce with what dose of injections, and that usually gives you an idea of how well the ovaries are functioning. Some sort of testing before IVF of the sperm also, of course, has to be done, such as, for example, a semen analysis or perhaps a post-coital test, a PCT. Freezing sperm before the IVF cycle, for many couples, especially in the frum community, is, I think, a very important thing to do. Certainly in cases of a severely low sperm count, or in cases where the husband is worried or thinks that he might have trouble producing sperm at the time that it's necessary during the IVF cycle, then it's important to freeze beforehand. It takes away all the stress, and we don't run the risk of having to cancel a cycle because we're not able to get a sample. And also, and this is where, for the frum community, it's a specific issue, for a particular frum couple where the dayan or the rav requires that the sample be produced b'shas ma'isa, then sometimes it can happen that it's time to thank you so much, I appreciate it. Thank you. Sometimes it can happen that it's time for the eggs to come out, which I'll show you in a little bit, but it's time to need that sample before the night of Tevilah. And if that's the case, then we won't be able to get a sample, so we need to have a frozen sample as backup from the previous month, from the month before, and I usually suggest that to couples in that situation. And finally, we have to get some kind of an evaluation of the cavity of the uterus, of the inside of the uterus, and that's very important before starting IVF in order to make sure that we're going to place the embryos into an environment that's as perfect as possible, that we can make as optimal as possible. And evaluations of the inside of the uterus might include these types of tests like a hysterosalpingogram or a sonohysterogram or a hysteroscopy where we put a little video camera inside of the uterus. Again, this is a subject for another discussion, but basically if an abnormality is found inside of the uterus, if there's something wrong inside of the uterus like a fibroid or a polyp or a septum or a band of scar tissue or whatever it may be, then we should really restore normal anatomy surgically before doing IVF. We should try to make the uterus as perfect as possible before starting IVF. And now we're ready to start IVF, and the IVF process continues to improve and be refined as science becomes more and more advanced in understanding the biology of reproduction, and as we become better at the clinical application of this biology. It's one thing to understand the biology, it's another thing to actually be able to help couples in accordance with that biology. The process of IVF is an extremely complex process which integrates the office, the operating room, the laboratory. It integrates surgeons, support staff, and embryologists, and of course it integrates patients, couples, their gametes, and embryos that are developed in the lab. The IVF process can really be grouped into 4 steps. I think it's most logical that way, beginning with stimulation of the ovaries. In a single normal menstrual cycle, the ovaries of a woman normally prepare a single egg for ovulation, just one egg, usually. In IVF, in order to try to optimize the outcome and make things as likely as possible to hopefully be successful, we have to hyperstimulate the ovaries. That means we have to cause the development of more than one egg, of several eggs even. And we have to do this, of course, in a very controlled and safe and carefully monitored way. The way that we usually do this is by the wife giving herself injections of hormones, such as FSH and LH, those hormones that we talked about, hormones that stimulate the ovaries. And we do that together with other types of injectable hormones that will prevent a premature ovulation, prevent the egg from coming out prematurely before we're ready for it to do that. Now, during treatment with those injectable hormones, we have to closely follow how the eggs inside of the ovaries are developing by monitoring blood levels of various hormones such as estrogen and progesterone and LH, and by actually looking at the ovaries on ultrasound, on sonograms. When the eggs are getting close to being ready, their follicles on the ultrasound, the balloons of fluid that they grow inside of, look like these black fluid-filled structures. That's what it looks like on an ultrasound. Once the blood work and the ultrasounds show that the eggs are getting close to the point of maturity, then they're ready to be removed from the wife's ovaries. And this procedure is now called the egg retrieval, which is sort of a funny word. Retrieval means taking something back to a place where it shouldn't be and putting it back where it belongs. So the eggs really belong inside of the ovaries. So I never quite understood why we call it the egg retrieval, but we call it the egg retrieval. That's just the Lashon that we use. The egg retrieval it's a surgical procedure which is done in the operating room. Usually it's done under general anesthesia, although it can be done also under other types of anesthesia like spinal anesthesia or even local anesthesia, sometimes even no anesthesia once in a great while. It's done transvaginally by passing a needle through the vaginal wall under continuous ultrasound guidance so that you can see on the ultrasound exactly where the needle is going so that it will not damage anything inside of the woman's body. And this is what happens. We actually insert a needle into each ovarian follicle and we remove the egg that's inside. That's a schematic picture, not an actual picture, a drawing of an ovarian follicle with the egg that is going to be kind of sucked into the needle and vacuumed out of the body. And this, amazing, this is the human egg. This is the egg. This is an actual picture taken from one of our patients as her egg looks under a high-powered microscope. This is magnified many times. The egg is actually the largest human cell. Believe it or not, most human cells you can't see without a microscope. The egg you can actually see to the naked eye as a little tiny dot. I usually tell people if you take a pencil and sharpen it to a sharp point and just gently touch that point to a piece of paper, that's what the egg looks like if you're looking at it with your eye. This is what it looks like, what it really looks like when you're magnifying it and look at it under a microscope. We get the eggs isolated, we identify them, we wash them, and we warm them up in drops of media, which is a nutrient fluid that's good for the eggs. And within a few hours later, the eggs are ready to be fertilized. Now, to bring about fertilization, and here's where we move to the next stage of the IVF process, we place the eggs into microdrops, which are tiny little drops of media, of this liquid. And we introduce usually about 50,000 washed, prepared sperm into each egg, into each drop of fluid. And at this point in the dish, the sperm do what they're supposed to do. They swim to the egg. There they are, swimming to the egg right there. The most successful one drills its way inside, which you can see happening in that picture and in this photo of a scanning electron microscope, and fertilization happens. This is fertilization. This is in vitro fertilization. Fertilization in the laboratory. In vitro literally means in glass, meaning as opposed to in vivo, which means in the body. If the sperm counts of the husband are very low, or if the motility of the sperm is very poor, if the way they're swimming is not so great, then rather than rely on the sperm to make their way to the egg, even in the petri dish in the laboratory, we can inject a single sperm directly into the egg. This is what we mentioned before, which is called intracytoplasmic sperm injection, or ICSI. Now in ICSI, we need only as many sperm as there are eggs. If we have 10 eggs, we need literally 10 sperm. That's it. And what we do is we draw a single sperm into a tiny little microscopic glass pipette. This is the sperm that's inside of the glass needle. And then, under a high-powered microscope, there it is. We place that needle into the egg, and we inject the sperm cell directly into the substance of the egg itself. Now, that substance, that jelly-like substance that's inside of the egg, it feels, when you're pushing that needle inside, it feels like jelly. And that's called cytoplasm. Every cell is filled up with this cytoplasm, and since we're injecting the sperm directly inside of the substance of this egg into the cytoplasm of the egg, that's why it's called intracytoplasmic sperm injection, ICSI. We're putting the sperm into the cytoplasm of the egg. ICSI can be done for various reasons. First of all, like we mentioned before, if there's a problem with the sperm, which is the reason for needing IVF in the first place, then usually we'll generally do ICSI. Second, if the couple went through IVF before, but none of the eggs fertilized with simple IVF by just mixing the sperm in the dish with the egg, then the next time they go through IVF, we'll for sure perform ICSI in order to try to improve the chances of fertilization. But third, really, and this relates to the second point, because of how devastating it is to go through IVF and not have any of the eggs fertilized at all and not have anything to lead to a pregnancy, so we often do ICSI on some of the eggs for couples who are going through their first IVF cycle. And we do it because we don't know at that point how well the eggs will fertilize on their own without ICSI. So in such a case, in a couple's first cycle, even if the sperm look completely normal, we'll often divide the couple's eggs in half and do ICSI on half of them and do IVF on half of them. We call that partial ICSI, in order to make sure as best as we can that in the worst case scenario, at least some of them will end up fertilizing. Now, embryo culture, there's a lot to talk about this. This is also the subject of a whole other talk. Embryo culture is where the embryos are grown in the laboratory for several days. And this has made tremendous progress since the early days of IVF. And with changes in the culture media, the type of liquid that we grow the embryos in, and the laboratory environment, those changes have had a very, very dramatic improvement in IVF and in how well it's been able to work. In the early days of IVF, embryos would usually be grown in open culture dishes, just open to the air, and they were placed in